I'm what they call the sweeper. I come up behind all those great lectures and try to present a case where you active sponges, use the knowledge you've learned to solve the case. Hopefully it'll work out as planned. It's also very stressful to do this job because I have a list of all the things I want to talk about, and every speaker just keeps knocking them off my list. So we're probably going to end on time. So these are my relevant disclosures. Of note is the first time I got COVID was at a Moderna ad board. So this is our case. He's a 33-year-old male flight attendant, MSM, who uses both insertive and receptive sex. He has no contributing medical history. He's otherwise well. Prior to this, he was on Descovy for PrEP, but he stopped at 9 months previously as he was laid off due to COVID and lost his drug benefits and was not able to afford it. He presented to the urgent care clinic with a 4-day history of an urethral discharge. He was treated with ceftriaxone and azithro on site. We use ceftriaxone because there's a lot of gonorrhea resistance in our community. Not only is he a flight attendant, but he's also a frequent flyer at our clinic. So we had a discussion about doxy-prep, and we performed the usual swabs. A rapid HIV test was performed, and it was positive to his surprise. He was then referred to the HIV clinic, and he was seen 48 hours in the HIV clinic, had a repeat rapid test, which was confirmed to be positive. He had not restarted his PrEP, so he was an individual who was not infected while on PrEP. Again, his medical history was not really contributory. He's received all of his vaccinations, and we collected his routine labs. So the first question then is, would you start ART as a rapid start? And so it's fairly difficult to do these cases when there's people online and in the room, but just as a quick in the room, how many people would say yes? And how many would say no? And how many don't know what rapid start is? Okay. So we all agree what the primary goal of HIV treatment is. It's to reduce the morbidity and mortality of HIV, improve the quality of life of our patients, and reduce HIV in our community by decreasing transmission with U equals U. So rapid start basically is the initiation of antiretroviral therapy as soon as possible after the diagnosis. And that's as soon as possible is a pretty broad term. It can be anywhere from days or weeks to even years, because sometimes we don't know how long our patients are positive. So the real key to rapid start is, do you start treatment before all the lab tests are back? If you do, that's a rapid start. So if you're starting treatment without knowing the viral load, the resistance pattern, the T cells, the HLA typing, then that's considered a rapid start. Personally, I'm not sure rapid start makes a huge difference unless, of course, we're talking about an acute seroconverter. But I have people who I have rapid started and other people who I have not. So what are the benefits of rapid start? Well, we talked about reducing plasma viral load both in the patient and the transmission of HIV, so the viral load in the community goes down. It creates a low HIV reservoir in the patient, especially if we're getting somebody early on in their infection. Faster viral suppression usually occurs because the viral loads will be lower. It decreases the morbidity and mortality. And for patients who are hard to reach or patients who we don't see very often, it gets them on therapy, and hopefully they'll stay on therapy. That, however, can also be a negative, because sometimes patients get on therapy and they get lost to follow-up. And we have a major problem in part of Canada called Saskatchewan, where we have a large Indigenous population who get on therapy, go back to their reserves, and are lost to follow-up. So getting people on therapy can be a plus and a minus from that social perspective. Other risks are the costs. Some patients may not have drug benefits in place and be able to afford medication. There's a huge psychological implication about starting people on therapy. They may not be fully accepting of their diagnosis. They may not be psychologically ready. They may have people they want to talk to about first. So rapid start does have its pros and its negatives. So assuming we're going to start therapy on this patient, doesn't matter if it's a rapid start or not, we have options. We have a single pill regimen, multiple pill regimen, and injectables. So how many people would start a single pill regimen? and multiple pill regimen, and injection. Pretty easy because injection is not licensed for treatment naive, but patients will always come in and say, well, what about the injection? Am I eligible? Because there's a lot of advertisement about that. In terms of assessing which one of these you're going to do, there's a lot of factors to take into consideration. The first one, obviously, is the size of the pill. There are some people who just can't swallow certain size pills. And so with that goes dosing intervals, goes psychological. Are they psychologically ready to start medication? Are they responsible enough to be adherent to their regimens? So you have to really assess patients properly to make sure you give them the right medication that's really going to fit into their lifestyle. Not so much a problem now, but with issues around ritonavir, for example, there was the need to refrigerate, and that caused a lot of disclosure to people, to their roommates and everybody else that they had HIV. So it's really important to put the whole concept together. I am going to be referring to the EACTS guidelines only in the treatment options here. Firstly, this is a European meeting. Secondly, I think the EACTS guidelines are the most inclusive because they have to meet such a broad population, and they're the ones that we generally follow in Canada more than any others. So assuming we're going to start a single pill regimen, we have some options. We have dolutegravir with nabacavir backbone. We have bictegravir with TAF-FTC. We have reltegravir with TAF-FTC, dolutegravir 3TC, doravirine tenofovir 3TC, and boosted darunavir. Does anybody have any preferences of what they would start?
Do you mean twice a day or once a day?
Good question. Well, it's a trick question because the question actually asks for a single pill regimen. And RAL is the only one that really is not a single pill regimen, but I have it there for a discussion point.
You have insurance now?
Sure. Yeah, he's back flying. I mean, the answer is all of them, right? There are all approved regimens in the EACTS guidelines. Clearly, you're not going to be able to use dolutegravir or bacavir 3TC if you're going to do a rapid start because you're going to need to do the HLA typing first. But you certainly could use dolutegravir and tenofovir FTC if so be it. You could also use dolutegravir 3TC, and I know there's some debate on the viral load. In our center, we generally get viral loads back fairly quickly within a week, and so we have done rapid starts with Dovato, dolutegravir 3TC, and see where they are a week later. Knock on wood, we haven't had any failures of that. We also don't see a lot of viral loads over 1 million, and I think in the 500,000 to 1 million range, people still respond well to Dovato. To Milosh's point about the reltegravir, reltegravir is a tricky one for us. We don't use very much reltegravir, but generally we only use reltegravir twice a day. We don't use it once a day. Reltegravir really is a BID drug, and I think the failures that we're seeing earlier on was when you were taking a BID drug and forcing it into a once-a-day market. So there's probably nobody in Canada, at least, who prescribes reltegravir once a day. But we generally prescribe bictegravir or dolutegravir if we're going to go for an integrase these days. In terms of a non-nucleoside, doravirine is the one of choice. It's co-formulated with tenofovir FTC. The caveats about hepatitis B, you clearly want to know what hepatitis B status of your patient because of tenofovir. But if you start somebody on a non-tenofovir based regimen, for example, dolutegravir 3TC, and they turn out to be hepatitis B, you can add tenofovir. You're not going to harm them in the amount of time that it takes to figure out if they have hepatitis B or not. There's been a lot of discussion about weight gain, weight loss with different regimens, and I know people have variable opinions on that. Generally, we don't use weight as a decision maker, so we don't start a drug or change drugs based on weight alone because we don't really understand where the weight's coming from. So the weight parameter does not come into play in our discussion.
Sorry, may I ask you something?
Sure.
I wonder, you say you have some options that you may want need to adjust when your laboratory results will come.
Right.
Do you already take it into account in discussion with the person with HIV? Because I think if you don't do that,
Right, no, we do, I'm not sure how things work in Europe, but there's a huge marketing campaign in Canada with pharmaceutical companies having billboards in every bus stop about the drugs. And so most of our patients already have a drug in their mind. Can I get that, you know, two drug in one pill? Can I get this? Can I get that? So we have that discussion, and most of the times we'll say, yes, we can start that. It might not be the right drug for you, so we might be changing it. So we do have that discussion up front. For the reasons you mentioned, we don't want to look like fools and say, oops, made a mistake. Yeah. Now, what happens if I change MA to be a cis female who's 32 years old? Does your option change in terms of what you want to start them on? These are the same drugs that I presented last time. Any comments?
You would have to consider contraception if she wants to have children. Still, she's 32, so she may still want to do that, and is changing the options slightly.
Right. Yeah. Yeah, and so the most reasonable option would be a dolutegravir-based regimen for this woman. Everything else still applies, the hepatitis B status and everything else, but dolutegravir really is the option of choice. Darufirine is included as an alternative. Sometimes that can be a little difficult to manage, especially in the later trimesters of life with of pregnancy with protein binding and stuff, but our preference is a dolutegravir-based regimen. Now, the EACT guidelines has about 10 or 15 pages of drug interactions. I'm only going to show you one. And this is really just to illustrate that as patients develop other medical illnesses and other medications, what you're going to use for your HIV is going to be influenced by those medical conditions and what drugs that they're on. And so sometimes it can be very complicated, and these charts, as you can see, can be very weighted with drug interactions. But if you have any doubt, the easiest regimens to use are integrase-based regimens. You'll see them mostly on the right, and for the most part, they're pretty clean. And that's probably consistent through most of those 10 pages of drug interactions in the guidelines. So if you're really not sure or it's really complicated, you don't have to wait to get an infectious disease or general medicine consult. Just start them on an integrase inhibitor. You're probably going to be okay, and if there is a minor change, your pharmacist will probably help you figure that one out. Now, we have seen a lot of cases of newly diagnosed HIV related to COVID, because patients who have been lost to follow-up who are HIV negative came in with COVID, and we did an HIV test on them and found out that they were HIV positive as well. And so, again, if there's any potential concerns about treating people for COVID, the cleanest drugs to use are integrase inhibitors. Again, there's very little interaction. Most of the interaction comes from ritonavir in other boosted PIs or non-nukes. So if there's any concerns about treating HIV and COVID, go with an integrase-based regimen. For patients who are trans regimens, testosterone does not really have any concerns. It's all the estrogen, progesterone hormones that are concerned. And so integrase-based regimens are the safest and easiest to use in people who are going through transgender. Everything that I said applies to changing regimens in people who are on established regimens, regardless of whether they're changing because of tolerability, side effects, viral failure, whatever. The only condition that gets added on in somebody who's treatment experienced is you want to know their drug history, and you want to know why they switched from one drug to another, and you want to know if there's a genotype. Because Laura mentioned today, I think this morning earlier on, about, you know, if somebody's been on 2 or 3 regimens but has never failed any of those regimens and simply changed for side effects, would you use Dovato? And the answer is I would. You know, if there's no history of failure, there's no reason that Dovato would be a weak agent to use. It has a high barrier. So that's the really most important thing to do, is know their drug history and why they switched medications. And I think I got us back on time. Our next place to go is coffee.